Hello everyone, myself Dr. Tarun Parmar. I am in UNMICRC. My today's topic is approach to a child with cyanotic CHD. So first of all, we'll describe the prevalence of congenital heart disease. That is 0.8% of the live births, and 3 to 4% of the stillbirths have said to have CHD, and 10 to 25% of the spontaneous abortus is said to have CHDs, and 2% of the premature infant has the CHD. We are excluding PDA here because otherwise 80 to 90% of the premature infant has the PDA. And this is the leading cause of death among the children with congenital malformations in any organ anomalies. We classify CHD based on saturation first. This is the broad classification in which if the saturation is more than 95%, then it is called the acyanotic CHD, and it is less than 95%, then it is called the cyanotic CHD. Again, in the acyanotic CHD, we describe it as classify it as increase in the pulmonary blood flow or obstruction to the blood flow from the ventricles. So increased QP situations are AST, VST, PDA, AVST, while obstructive situations are AS, PS, and coarctation of aorta. Again, in cyanotic CHD, we describe as increase and decreased QP situation. So decreased QP situation or decreased pulmonary blood flow situation are VST, PS situation, or any pulmonary stenosis with large VST situation. These are TOF, DRV, VST, PS, tricuspid atresia type 1B, and other is mixed blood flow, that is either normal or increased pulmonary blood flow. These are the TGA, TAPVC, truncus arteriosus, etc. So there are lots of association between the CHD and genetic and chromosomal anomalies. Commonly we know trisomy 21, then Turner syndrome, then Edward and Patau syndrome, Fragile X syndrome, Dijors syndrome. This all has this chromosomal anomaly has the CHD association, as well as when we find the CHD in any patient, we have to actively look for the any chromosomal anomaly or any genetic abnormality, because we need to prognosticate the patient. We need to see any other organ anomalies are involved in or not. So the important thing about CHD is when the patient present to you, because the first month of life is very critical. If the patient is presenting during the first month of life and requires any surgical or major intervention during the first week of life, we classify it as a critical CHD. So which are the lesions that are present during the first month of life? Most of these lesions are duct dependent lesions. So duct dependent pulmonary circulation or duct dependent systemic circulation are the ones that present during the early days of life. And then TAPV situation with obstruction or increase AV pressure like AV fistula, this patient present earlier. So which are the ductus dependent lesion? Ductus dependent pulmonary circulation situations are pulmonary atresia with intact ventricular septum, TOF with severe pulmonary stenosis, TOF with pulmonary atresia, or tricuspid atresia with severe pulmonary stenosis, or abstinence anomaly. These are the functional pulmonary atresia situation in the abstinence anomaly most of the time. And then duct dependent systemic circulation are critical coarctation of aorta, then critical AS, aortic atresia, interrupted aortic arch. These are the duct dependent systemic circulation situation. These present during the first week of life, during first few days of life, when duct is about to close during the first 3-4 days of life. And then the second presentation of age is at the 4 to 6 weeks of life when the PVR drops. So most of the time these are the post tricuspid shunt with increased pulmonary blood flow. When the PVR drops, the increase in the pulmonary blood flow will lead to the increase in the left to right shunt and increased pulmonary circulation. These are the VST, AVST, large PDA, and notably Al-Kappa is also present during this age group. So let's discuss about the definition. So what is the definition of the cyanosis? Cyanosis, the word came from the Greek. This is known as a dark blue. This is a dark blue, bluish discoloration of the skin, nail bed, or mucous membranes. If the cyanosis is limited to the extremities, this is known as the peripheral cyanosis or acrocyanosis. This is very common during the neonatal period. So when do you detect the cyanosis? Clinically detectable cyanosis, when saturation is less than 85%, and then only you can clinically detect the patient is cyanous. Otherwise you cannot, you do not perceive this patient as having the cyanosis. So the gray zone is 85 to 95% of saturation. Less than 85 you can perceive it. Between 85 to 95% saturation you cannot visually perceive. So you have to have measurement of pulse oximetry during that time, and more than 95 is a cyanotic patient. So cyanosis to occur, you have to have reduced hemoglobin of more than 5 gram per deciliter. So this is the pictorial representation of what is acrocyanosis and central cyanosis. Acrocyanosis or peripheral cyanosis is when the periphery, or the hands and foot are cyanosed, but tongue and lip and nail beds are pinkish. This is situation where the neonate is having hypothermia, and that is our vasoconstriction. During this thing, patient is having peripheral cyanosis, but central cyanosis occur in the cyanotic CHD patient, when you can clearly see the lip and tongue is cyanosed. This another picture is showing the baby during the TAT spell. So there is influence of hemoglobin level in the clinical recognition of cyanosis. Why? Because we need 5 gram per deciliter of reduced hemoglobin into the peripheral circulation, into the venules, to visibly see as cyanosis. But when there is a severe anemia situation, then reduced hemoglobin because hemoglobin is very low. So in that particular situation, the visible cyanosis occurs when there is desaturation is very less. While in polycythemia situation, you can clearly see the cyanosis even if the saturation is above 85%. So let's come to the approach. So in approach, we have to see history and evaluation of the cyanosis, then increase and decrease pulmonary blood flow. Then we have to auscultate the patient. We have to see for the heart sound, and particularly the second heart sound. Then we have to particularly look for the murmurs, and then evaluate the chest X-ray, ECG, and then 2D echocardiogram. So history and symptomatology. If we see cyanotic CHD with increased pulmonary blood flow, so what are the symptoms? What are the presentation of this patient? So first we see the decreased pulmonary blood flow. So in this situation, patient presents with cyanosis that is gradually progressing, and then there is squatting episodes are there. So in top situation, if you see, patient will be normal during the first few days of life, but the cyanosis gradually progress when the pulmonary stenosis increasing gradually. This patient also have fatigue, then hyperviscosity related symptoms. Then these patients are failure to thrive. They have lower than normal IQ. The IQ, that doesn't mean that patient is having particularly lower IQ, but their scholastic development and scholastic performance is not as good as the other counterpart. And you can also see the improvement in these patients' scholastic performance after surgery, after you give them the normal saturation and syncope. These are the normal presentation of the patient with cyanotic CHD with decreased pulmonary blood flow. And cyanotic CHD with increased pulmonary blood flow, these patients present the same way as acyanotic CHD with increased pulmonary blood flow, but these patients are presenting early and having more severe symptom during the first few days of life. So these are the congestive heart failure, then sweating while feeding, there is success cycle, respiratory distress, increase in the respiratory rate, recurrent lower respiratory infection, and feeding difficulty, and failure to thrive. These are the most common presenting symptoms of the cyanotic CHD with increased pulmonary blood flow. So this is the chart that's showing the symptoms and when it appears and how it progresses. So you can see the cyanotic CHD with increased pulmonary blood flow, they are more symptomatic, they present early, and they never become normal, and usually they having the worst course during amongst all these patients. While cyanotic CHD with decreased pulmonary, these patients also never become normal, but their symptoms are little bit lesser. They are less sick than the cyanotic CHD with increased pulmonary blood flow. While the acyanotic CHD with increased pulmonary blood flow, left to right shunt situation, they are usually normal during the birth, but they become symptomatic at 4 to 6 weeks of life. They remain symptomatic during the first few years of life. Then the shunt become right to left or bidirectional, and then they become somewhat less symptomatic, and then again they become symptomatic during the later years of life during the Eisenmenger period. So, evaluation of the cyanosis. So, first thing first, you have to differentiate between the cardiac and the non-cardiac. So, most commonly is pulmonary. So, the reason behind the cyanosis or decrease in the saturation, that can be pulmonary. So, what are the differentiating feature? In the cardiac cause, patient is comfortable at rest, while in pulmonary, patient is having the respiratory distress. There is a increase in the respiratory rate and intercostal and subcostal indrawing in the chest. Then in cardiac, this worsens on crying, while in pulmonary, it improves on crying. Then resting PO2 is less than 60 millimeter of mercury in the cardiac patient, where pulmonary resting PO2 is more than 100. This is very important, hyperoxia test. So this is very important test to differentiate between two. So PO2 does not increase much in the cardiac patient with right to left shunt, while PO2 increases to 150 to 200 millimeters of mercury. Saturation is, as you know, is below 95 percentage, while saturation is almost normal or more than 95 in the pulmonary situation. And then ECG, X-ray are abnormal and echo is abnormal in the cardiac patient, while chest X-ray is abnormal in the pulmonary. Otherwise, ECG, echo is normal in the pulmonary situation of the desaturation. So now we come to a very important test, that is hyperoxy test. So how you differentiate between the cardiac and non-cardiac cause of the cyanosis? So what we have to do is first you check the PO2 at the room air, and then you have to give 100% FiO2 for 10 minutes, and then you have to again check for the PO2 by ABGA. So what will happen if PO2 remains less than 100, then cyanotic CHD is likely. While PO2 is 100 to 150, then cyanotic CHD possible. But PO2, if PO2 is 100 more than 150, then cyanotic CHD is unlikely. So we practically rules out cyanotic CHD by looking at the PO2. So exception is TA-PVC. Most commonly the infracardiac TA-PVC. We'll see why this happens in the next few slides. So this is one misleading hyperoxia test in which this is one case report reported, in which the patient is having infracardiac TA-PVC with open ductus venosus. So what happened in this particular case, they have checked the PO2 during the first few days of life, and it was more than 150, and they sort of ruled out cyanotic CHD and treated the patient as a respiratory symptom and respiratory condition. But after few days, the patient is not improving, and again they repeated the hyperoxy test, and at that time PO2 was lower, and then they did the echocardiography, and then they found out this is the infracardiac TA-PVC, because ductus venosus is now closed in this situation. So these few instances are there that will mislead the hyperoxy test. Otherwise, hyperoxy test is very accurate. So why this hyperoxy test is important? So, in real world scenario, I can tell you that when you are at the tertiary care center, so in that center you have the cardiologists available, you have equipment available like 2D echocardiography machine and everything. So in that situation you can easily go and diagnose the patient having cyanotic CHs like TGA or TA-PVC or whatever. But the center where echocardiography is not available, the peripheries where these facilities are not there, or trained personnel is not there. So in that situation, you can actually rule this thing out by doing hyperoxy test. Like 1 week before, one of my colleague called me, pediatrician from the periphery, and he told me that one patient is having desaturation, and the patient is on the ventilator and saturation is not improving. We have done the echocardiography. Echocardiography was done by not the person who trained to see the congenital heart diseases. So he has sort of given the report like RARV is dilated, there is moderate TR and severe PAH, and PF or AST is shunting right to left. But he or she is not sure about the pulmonary venous drainage. So and other conditions. So I told him to do hyperoxy test, and when they did the hyperoxy test and PO2 is turned out to be low, then I told him that this is a cyanotic CHD, most probably TA-PVC situation with obstruction, because patient is very symptomatic during the first few days of life, because unobstructed TA-PVC do not present like this. So they shifted the patient immediately, and then we checked the patient. It was supracardiac TA-PVC with obstruction. So we have operated the patient on the same day. So these are the situation where this is practically most important thing. So one good thing if you take away from this talk is doing the hyperoxidase. Again, one more example I remember. In this case, in that case, the patient was misdiagnosed as having the only small VSD, and by echocardiography, again by the person who is not trained to see the CHD patients. And then the pediatrician suspected this patient having cyanotic CH because saturation was very low. Then they did the hyperoxidase and PO2 comes out to very low. And then they shifted the patient to our center, and it was turned out to be TGA with small VSD. So hemodynamically that patient is behaving like a TGA with intact IVS. So what will happen if the patient if you delay such type of patient for 3 to 4 months, so what happen? Either patient may die because this is a TGA situation, or if the patient survive, then the LV become regress. So in this situation, you are very late to diagnose this thing. So this hyperoxidase is very important in the periphery situation where the trained personnel is not there and when such facilities are not there. So we come to the cyanotic CHD with decreased pulmonary blood flow. These are the top physiology or VSD-PS physiology where there is an intercommission between the two ventricles and there is pulmonary stenosis situation. So what are those situations? These are at TOF, DRV, VSD, PS, triatresia with PS, single ventricle with pulmonary stenosis, TGA, VSD, PS, LTG, VSD, PS and AVSD, PS. So like we see the different anomalies individually, like in TOF, tetralogy failure, symptomology depend on the degree of the pulmonary stenosis. What is on the physical examination, we can see the single accentuated S2 and ejection systolic murmur. In chest X-ray, CTR may be normal. There is decreased pulmonary blood flow or decreased QP on the X-ray, and ECG showing right ventricular hypertrophy, right axis deviation, and the early transition of R wave from the V1 to V2. So this is the pictorial presentation of squatting that is normally seen on the TOF patient or TOF physiology patients. So in the TOF situation or URV VSD PS, triatresia VSD PS, single ventricle PS. So the most important thing to understand in cyanotic CHD with decreased QP patient is cyanotic spell. So why we need to understand this very well, because we need to recognize the spell and we need to treat them as soon as possible, because this is the critical situation and it will lead to the hypoxic damage to the brain, and every single second is important because it will lead to irreversible neurological damage when hypoxia is prolonged. So this happens, cyanotic spell, during crying or decrease in the SVR or spasm of the RVOT, and ultimately the final result is increase in the right to left shunt, and it will lead to the hypoxia, and then it will lead to the increase in the carbon dioxide and then acidosis. This will lead to tachypnea, and this is a vicious cycle, and if this continues and continues and continues, the patient will be having very low oxygen saturation. Patient might go into convulsion, patient might succumb to death if this vicious cycle is not broken. So what to do during the cyanotic spell? The first thing you have to diagnose this is a cyanotic spell. So one thing you have to do is differentiate between the breath holding spell and cyanotic spell, and then you have to check the vitals, and then when you diagnose this is a cyanotic spell, then you have to give Nietzsche's position to increase the SVR, and then oxygen, you have to give the oxygen if it available, then IV fluid, the bolus you have to give 10 to 20 ml per kg, then morphine you have to give 0.2 mg per kg subcutaneous or intramuscular, then soda bicarb, then propranolol, IV beta blocker, and then ketamine, and so on. So you have to go on and on and on until the patient is relieved, patient saturation is improved, tachypnea is abolished, and patient become normal. If it is becoming more and more worsen, then you have to give vasopressing agent, and then ultimately if it is not improving, then you have to intubate the patient and put the patient on the anesthesia, and if still not improving, then you have to go for the immediate emergency surgery. So what are the surgical options of the TOF patient? These are the BT shunt initially if the anatomy is not suitable for the ICR during the early stage of period, or you can go for the intracardiac repair. Second, cyanotic CHD is TGA. In this patient, either associated AST, VST or PS. On examination, patient is having single S2 and VST murmur may be present. Chest X-ray is egg on side appearance, and there is cardiothoracic ratio is normal to increase and increase or normal QP. ECG showing right ventricular hypertrophy. TGA management is depend on the either interventricular septum is intact or there is VST, and depend on the anatomy of coronary arteries and all these things. So initially, if the patient is having the small PF1, patient is very sick, we have to go for the BAS. If that is not there, then first 1 or 2 weeks we go for the arterial switch operation. Then pulmonary atresia with VST. These are the top VST patients. So we are not going in detail with every patient here. So pulmonary atresia VST management also depend on the pulmonary circulation. If it is and depend on the size of the pulmonary arteries. Likewise, tricuspid situation, this is a single ventricle physiology. So in this condition, there is single S2, VST murmur may be present, and ECG showing superior axis and right atrial enlargement and LVH. Management is single ventricle physiology, so you go for the either BT shunt in the initial phases and then BDG and Fontan later on. TAPVC, you have to diagnose it very early if it is obstructive TAPVC. In obstructive TAPVC, you have to go for the emergency surgery. Otherwise, you can plan it at 4 to 6 weeks of age. This is the example of the supracardiac TAPVC. It is clearly showing the different pulmonary veins draining into the common chamber and draining into the ascending vertical vein. So treatment in all these patients is correct the acidosis, then anti-failure treatment, and then surgery is the definitive treatment. This is the echocardiography of the abstinence anomaly. So here we come to the differential diagnosis of important clinical, important cyanotic CHD with increased pulmonary blood flow. So how you approach this patient? So if the severe cyanosis at birth and severe cyanosis at birth, then single S2, cardiomegaly, then no murmur or ejection systolic murmur, and ECG showing RVH and egg-shaped heart on the X-ray, then likely this is the TGA. You are dealing with the TGA situation. This is not a foolproof, but these are the some of the clues that will differentiate from one CHD to other CHD. So in TAPVC situation, mild cyanosis at birth, wide split S2, cardiomegaly, then tricuspid flow murmur or diastolic and pulmonary murmur will be there. ECG showing right ventricular hypertrophy. Then you are dealing with the TAPVC situation. In TOF, cyanosis is usually not present at the birth, as we said that usually progresses as age progresses. No congestive heart failure, normal size heart, pulmonary ejection systolic murmur is there. There is single S2 and boot-shaped heart on the X-ray. These are the findings in the TOF. Then tricuspid atresia, similar to TOF, except there is a left ventricular hypertrophy and hepatomegaly. And likewise, pulmonary atresia situation and abstinence anomaly, there are different markers that can differentiate one condition from the other condition. So again, the diastolic murmur is cyanotic CHD. In which condition you can listen to diastolic murmur? Maybe due to AR in the TOF pulmonary atresia situation. In this situation, there is aortopathy, and that will lead to the dilated aortic trunk and AR. In truncus arteriosus, valve is usually malformed, so that will lead to the AR. In the and then pulmonary regurgitation that happen in the Eisenmenger due to very increase in the pulmonary arterial pressure. And then TOF with absent pulmonary valve syndrome, there is to and fro murmur in this situation. and then due to tricuspid inflow you can hear that diastolic murmur in the abstinence anomaly or TAPVC situation. Pansystolic murmur in cyanotic CHD usually happen in the AVST with heavy VR or Chd-Cce with abstenoid tricuspid valve with TR. Continuous murmur in cyanotic CHD most of commonly you can appreciate in due to PDA, like TOF with PDA, pulmonary atresia with VST with collateral. You can listen to the continuous murmur on the back in this situation, then due to having BT previous surgery. So what is the practical approach to cyanotic patient? So first thing first, if the patient is having the cyanosis, so rule out acrocyanosis or cyanosis due to extracardiac cause, mainly the respiratory cause. If you are confirmed then this is cyanosis due to congenital heart disease, then you have to do the hyperoxy test if you are not sure. In this hyperoxy test, if PO2 is significantly improves, that rules out the cyanotic CHD, but PO2 is failed to improve, then you can tell that this is cyanotic CHD with cyanotic CHD condition. So PO2 is less than 100 millimeter of mercury, then this is failed hyperoxy test. Then you have to go further for another evaluation. In that case, you have to do chest X-ray, echocardiography and ECG. Echocardiography is the hallmark in this situation. So now once you do the echocardiography, what you have to do? You have to rule out the ductus dependent flow. So either it is ductus dependent pulmonary situation or ductus dependent systemic circulation, because in that situation you have to start for the prostaglandin E1. And once you do all these things and you are sure that this is cyanotic or acyanotic CHD with increased or decreased QP, then you have to refer to the patient to the higher center for surgery. So what are the ductus dependent lesions? So ductus dependent systemic circulation are hypoplastic left heart syndrome, critical AS, shown complex variants, coarctation of aorta, interrupted aortic arch. These are the situations where duct is required to for the systemic circulation. And ductus dependent pulmonary circulation is TOF with pulmonary atresia intact ventricular septum, critical PS, tricuspid atresia with critical PS, single ventricle with critical PS for pulmonary atresia situation. Severe abstinence anomaly in where there is functional pulmonary atresia. These are the ductus dependent lesion when you have to give prostaglandin E1 as soon as possible to sustain the life. So when to start prostaglandin? So critically ill newborn with cyanosis, murmur is present, then you can start it without doing the echo. Then non-cyanous critically ill newborn, if the presence of an abnormal pulse, you can start. No 2D echo is required if urgent life-saving situation, because if you suspect that patient is having this cyanotic CHD or acyanotic CHD but duct dependent lesion, by looking at the patient, by examining the patient, and then you can always start prostaglandin E1. So these are the medical management of a duct dependent lesion. You have to start the prostaglandin, then you have to give accurate dose of the prostaglandin, and the side effect you must be knowing that this is dose dependent side effect. So most common is apnea, then fever and flushing and hypotension. And if apnea occurs, then you can give aminophylline or IV caffeine. In this situation you have to give inotropic support if there is hypotension. So now come back to the X-ray. This is the normal X-ray of the child. So these are some of the X-rays of the CHD. This you can see clearly, this is boot-shaped heart and there is decrease in pulmonary blood flow. This is classic X-ray of the TOF. In this X-ray you can see there is dilated pulmonary arteries, hugely dilated pulmonary arteries. There is decrease in the pulmonary blood flow, and RV type of apex is there. This is TOF with absent pulmonary valve syndrome X-ray. In this X-ray, if you can see, this is snowstorm appearance X-ray. In this this is TAPVC X-ray actually. So increase in the pulmonary blood flow and figure of 8 in this X-ray. In this X-ray, you can see typically normal or increased QP, egg on side appearance. This is a classic X-ray of the TGA patient. So, what are the clues from the X-ray to go towards the diagnosis of the CHD? First, you have to see the cardiac size, either cardiomegaly or normal cardiac size, then pulmonary blood flow or vascularity, there is increase or decreased QP, then which ventricle is dominant, like RV or LV dominance, and then you have to see for the aortic arch, is the right aortic arch or left aortic arch, and then the classical X-ray findings like boot-shaped heart in TOF or tricuspid TOF or pulmonary atresia situation, then egg on side appearance in the TGA or snowman appearance in the TAPC situation. So these are the different X-ray findings we have described. ECG also you can, there are peculiar thing you can see in the ECG that will lead to the diagnosis, like RV forces you can see in the TOF and DURV patient, TOF with pulmonary atresia, TGA, TAPVC patient. LV forces you can see in the tricuspid atresia, pulmonary atresia, IVS, hypoplastic right heart syndrome, single ventricle physiology, mainly DILV situation, abstinence anomaly. And then biventricular forces you can see on truncus arteriosus, DORV. Normal ECG in the anomalous systemic venous return and pulmonary AV fistula situation. We discuss a commonly occurred real life scenario that happened during our clinical practice. That is to differentiate between the obstructed TAPVC and respiratory distress syndrome. So why this happened? That patient looks very severely ill in both of the situation. Patient is having a respiratory distress, sinus, and even if you see at the echo, then if you do not delineate the pulmonary veins, the echo will be the same, like RARV is dilated, there is moderate to severe TI, there is severe PAS, PFO is shunting right to left, and patient is sinus, and RV dysfunction is there. So in both situations, like PPHN situation or RDS situation and obstructive TAP situation, these internal things are the same, unless and until you delineate the pulmonary veins that is draining to left atrium and rule out the obstructed TAPVC. Then and then only you can differentiate these things. So in clinically what you can see in obstructed TAPVC patient is sick, severely sinus, feeding difficulties there, poor perfusion is there, metabolic acidosis, tachypnea, S2 is fixed split, then no murmur or mild systolic murmur, venous sum may be due to obstruction, X-ray normal heart size and ground glass appearance, X-ray normal heart size and ground glass appearance. This can happen in both the situation, like ground glass appearance. And RDS situation, this is very early onset respiratory distress, grunting respiration is there, maternal history of diabetic mellitus, premature baby, this will happen more commonly in premature baby, history of LSES may be there, and X-ray you can see air bronchogram, patchy distribution, then obliteration of the part of the entire cardiac cell hood. So the left side of the X-ray is this TAPVC X-ray, but and the right side of the X-ray is RDS situation. This is ground glass appearance of the patient. So how do you differentiate between this? One thing is you do the hyperoxidase. Second thing is by expert cardiologist, you delineate the pulmonary venous return to the LA or pulmonary veins going to the common chamber in the supracardiac TAPVC or CES in the cardiac TAPVC or descending vertical vein in the infracardiac TAPVC. So this is one case scenario that happened in our OPD. This is the patient. Can you see this thing? I mean, is the patient is sinus? Saturation is 92%, and this is echocardiography. So here you may not differentiate as sinus, but saturation is 92. That is less than 95. That means sinus. And this is the echo image. This you can see the all four pulmonary vein forming a confluence draining into the CES and right atrium. This is the diagnostic echo image where you can see the dilated coronary sinus draining into RA and then ASD shunting right to left. You can clearly see there is a whale tails appearance all the four pulmonary veins draining into coronary sinus and draining into RA. This is the cardiac TAPVC situation. So this is how you differentiate between the acyanotic and cyanotic CHD and CHD versus other respiratory anomalies. So to conclude, the approach to cyanotic CHD patient, you have to have the comprehensive approach to the child. In this we have all discussed about the history and evaluation of the cyanosis. That is most important thing. Then you have to see for the increase and decrease in the pulmonary blood flow. Accordingly you classify the condition, and then heart sound, you have to listen to the heart sound, second heart sound and murmur, and then evaluate the chest X-ray, ECG, and finally the 2D echocardiogram. By doing all these things, and hyperoxygenase is the most important thing in this condition. By doing all these things, you can approach a patient of cyanotic CHD, and then after doing all this investigation and spatial investigation, and then you can classify them and send them for the surgery or intervention which is required for the patient. Thank you.